Dr. Lim Kiak.
Thank you, Madam Speaker. First, let me just declare my interest as a member of the medical profession. I'm a practicing ophthalmologist in the private sector. I would like to also commend and congratulate Minister Ong Ye Kung and the team over at MOH for a very bold and forward-looking Healthier SG white paper. You know it is a good paper when many members suddenly rise to the occasion and start to claim credit for it. So everybody will quote their own previous adjournment motion, COS debate, and what for. And in this in particular, this joint, I think I would like to join them as well. Let me claim credit for putting forward that to suggest there must be an adult immunization schedule, that we should put forward, previously. This paper itself will transform our healthcare system into one that is preventive. It is a paradigm shift because most of the patients, only when they are ill, they will see a doctor. If you are not ill, you shouldn't see a doctor at all. Most of the doctors will only see patients when they are ill. If the patients are well, they don't see the patients. So it is very different. I'm not sure even you should call them patients in the first place, because now they are not ill at all. So it's a complete paradigm shift. Maybe clinics have to change their name. They shouldn't call clinic, they should be called wellness center, because they are there for wellness. They're not there for the sick. So in the transition, that is the difficulty. To have a paradigm shift, you have to change the mindset of both patients as well as GP, as well as the population. I think that is the enormous task that MOH have now ahead of you. First, let me just congratulate for taking this very bold step, one small step ahead, but it's a bold step for the nation. I totally agree with the white paper and support the white paper. All those proposed initiatives are commendable, but there are many areas of concern, like my colleagues, my parliamentary colleagues has raised up. The details is always in the executions, and the problems are always there. I would like to focus my speech on two areas. One is the one resident, one doctor scheme, and how this will potentially affect the patient as well as the GP. Like many of the parliamentary colleagues, I do have my family doctor, Dr. Tan, that was in Nee Soon Clinic, that looked after me, looked after my family when I was young. I'm very grateful for that. It is one GP clinic that looks after the entire extended family. My grandmother, my grandfather. He was the one who came and signed the death cert for my grandfather or my grandma as well. So I think we are quite familiar with the relationships of one good GP to a family. A good family physician can do, and that's something. The current white paper now dictates that it should be one doctor and one family doctor to one resident. I think it is a good idea, but our current GP practice now are no longer like those that was in Nee Soon Village. It's no longer solo practice. Most of them are in group practices now. In fact, they are big group practice whereby doctors always change. So you may not see the same doctors all the time. If your scheme now is to be attached to the clinic, then does it defeats the purpose of this white paper, in the sense that you do not build relationship between doctors and patient, but it's just clinic and patient. So I'm not sure how does that change the paradigm. It's very similar to the current polyclinic system now, whereby my residents always complain when they go to polyclinic, they see different doctors all the time. So the only thing that held everything together is good medical records. When you have good medical records, then it makes a big difference. So I think key thing now is your IT, is to make sure that medical records are seamless, so patients do not need to repeat everything. Doctors do not need to look through a lot of other records in order to find out how to manage this particular patient or resident. In established healthcare system, in developed countries like UK and Switzerland, access to healthcare starts from a regular GP or family doctor. When doctors have a good long-term working relationship with their patients, they can harness the power of this relationship to solve problems beyond what may be too complex for other healthcare professionals, such as those pertaining to social and lifestyle challenges as well. As a doctor with regular patients, I can certainly attest to the effectiveness of such working relationship, where both parties have mutual respect, trust, and confidence, which is the most important. As I mentioned earlier on, many GPs are now in group practices. GP rotates themselves between clinics, and if patients are enrolled to a particular doctor, they may find it very difficult to reach to this doctor at a preferred location on certain days or certain time. Under such circumstances, of course, the patients will be attached to the clinic instead. If the enrollment is based on clinic and patient sees different doctors, then the question is, of course, what is the value of that doctor's-patient relationship? Some patients would prefer doctors that is not in their healthcare cluster, not within their area of residence. I think Minister has mentioned that they can sort of switch GP. If the patient can switch GP, can they also switch cluster? That's the next question. Can Minister also help us to clarify whether GP in a particular healthcare cluster, can they refer to the specialists in other clusters? That's especially for existing patients who have been seeing the particular hospitals for a long time. This is important as patients may want to exercise more choice over their preferred specialists. And the reverse is also true, in a sense that with the specialists, can they refer patients now to the GP or the polyclinics within their healthcare cluster for step-down care? If the patient prefers to request to go to their preferred GP, will this cross-referral and transfer of medical history be conducted seamlessly? And will cross-clustering further complicate funding of the programs as it is funded by clustering? Then there are patients who go to their company's medical group to utilize their company's medical benefit. Employees these days are spending fewer years working with the same company. This means it will be very difficult to forge the long-term relationship that we hope to achieve through this one resident, one doctor scheme, if they are switching doctors every few years under the company scheme. How does the government plans to counteract for this? The enrollment of 1-to-1 GP will still allow patients to use their CHARS and other GP clinics. And this does not allow for stickiness to one GP, and patients will still go GP hopping. This is a feedback that I got from my GP colleagues. And of course, GPs are GPs. There will be GPs that are very popular. I'm afraid that when this enrollment starts itself, the very popular GP will be all fully booked out. It's just at the good schools, MOH may have to start a balloting system, for patients, to book their favorite GPs. And last of all is that, can GPs choose their patient? Which means that, are they allowed to reject patients who choose them in the first place? If that's the case itself, then yes, then by right, GP groups or GPs can cherry pick. They can choose patients who are well, who do not need so much care, much more cooperative compared to those that are not so cooperative. As for the age of entry, disease prevention, especially for chronic diseases, is the focus of this white paper. I was wondering why did Ministry choose 60 and above as the entry age for the program? In fact, 60 and above is where chronic diseases starts. At 60 and above itself, like what my parliamentary colleague Sharif just mentioned, 1 out of 10 will be having early dementia. It's a bit too late. If you want to prevent dementia, you should still encourage them to start walking at 40 years old. If you walk 4,000 steps a day, it reduces your risk by 20%. If you walk 10,000 steps a day, it will halve your risk straight away. So in that case, you do not need to build so many expensive dementia management centers, if you start that program early. So the question is, of course, ideally the implementation age should be 40 years and younger, not older. The earlier the start itself, the easier to manage chronic diseases. In fact, we are here not managing chronic diseases, we're trying to prevent chronic diseases. By the time you hit at 60, you're actually managing chronic diseases. So there's a difference between that. So the essence of the white paper is to prevent disease from forming. Of course, we also want to make sure that chronic diseases are well managed, they do not progress to become more serious in the first place. Then last of all is encouraging participation. Free medical checkup, vaccinations are undoubtedly attractive for boosting our participation, yet there will be residents who are unconvinced. Even our free COVID-19 vaccination program, when it comes to the mind, there are people who will refuse the vaccination. There are also regular functional medical screening via the Project Silver Screen that is held at the Heartlands, free for seniors over the 60. Not everybody will sign up. I have older folks who do take care of their health through good lifestyle habits, like regular exercise, eating healthily, but there's aversion when it comes to ask them to go for medical screening or seeing a doctor, especially when they are not feeling unwell. Preventive healthcare does require commitment on the patient's part. It is unlike a simple medical consultation where patients see doctors because they have symptoms. After they see the symptoms, they get treated, they go home with medical prescription, and that's the end of the transaction. Whereas preventive healthcare is a long-term journey. The concept itself is relatively recent, and what else can you do now as a government now to encourage the active participation of the population in preventive healthcare? Because it is really a big paradigm shift. for all our patients, or rather for all residents. A big part of it is funding. I shall talk about a little bit on remuneration for GPs. This I must first not take credit for my own. I must credit my GP colleagues who have emailed me when I asked them for what is your feedback on Healthy SG paper. So the first thing they were asking me was, how is the funding model? Many GPs are concerned with the remuneration model as they believe that the new scheme will add considerable more workload for them now. MOH has announced that it will be annual service fees for each enrolled resident, which will vary according to the risk profile, scope of care, as well as progress made. The fees are based on patient's progress rather than service, which I think could be challenging to measure objectively. I think the argument of what KPI to set, how to measure, already started in this house already. A younger patient who is more receptive to advice will naturally make more progress than the older patients with more chronic health problems and may be more resistant to changing their lifestyle. Can the ministry now provide a clearer outline on how the GPs will be remunerated? While I believe that most doctors want to make a difference to their patient's life, if they feel that if they feel that they are not compensated reasonably for their time and effort, some will choose not to participate in this particular scheme. In short, my concern is that whether GPs itself, how do you empower them? Also, how do you make sure that GPs don't cherry pick at the end of the day? That's the tough part. That's the tough balance that you have to balance. In terms of drug pricing to be made comparable with polyclinics need to be handled very carefully, as GPs do earn from the sales of proprietary drug. The uneven rollout of drug pricing by January 2024 itself may lead to residents preferring to see at polyclinic instead of GPs. That's one feedback that I got from most of the GPs. I also want to voice a concern from my GP colleagues about the IT enabler for GPs. The incentive for GP may not be worth the extra time and effort because in January 2023, which means the next year, the solo GP and his clinical assistant must do an enormous amount of work. While clusters can help him and his patients to connect to the social and community partners, he still has to see patients in an efficient, timely manner and ensure outcomes indicators as well. This can be a daunting task for many GPs. They won't receive payment for their work right away. It may be a year later. So we need to walk this journey with the GP and scope this launch very carefully. The next topic I'm talking about will be the participation from the healthcare cluster. I know that the 3 healthcare cluster will be involved in keeping the residents' population healthy and will be set up as regional health manager. Can the ministry share now what are the specific KPIs now for the healthcare cluster and how will these KPIs be tracked? I would also like to raise the concern for small GP groups as well as independent GP may find themselves at a disadvantage as compared to the big groups who have clinics spanning over all 3 clusters because their market will be very limited. Last of all is preventing GP burnout. I echo some of my parliamentary colleagues over here. In UK, the NHS system, GPs form the bedrock of their entire healthcare system. The healthcare journey for every patient starts with the GP first. In recent years, GP practices across the UK face significant and growing strain with declining number of GPs and rising demand, struggling to recruit and trying to retain staff as well. This translates into longer waiting times, poorer service for patients. According to the data from British Medical Association, the overall numbers of GP partners have been on a decline in recent years. Since 2017, the number of GPs working full-time or more in GP-based practice has been steadily decreasing. More GPs choose to work part-time as they have better control of their hours as workload to improve work-life balance, reduce stress and burnout. Besides learning about the heavy workload and long hours, NHS GPs has expressed their unhappiness on how their contributions, their abilities have been undervalued compared to the specialists. They also face increasing abuse from patients as well. We must learn from these countries with similar model and recognize the benefit, but see how can we avoid the pitfall. For our shift in a healthcare policy to be successful, we need adequate GPs to be working regular and reasonable hours to minimize burnout and to ensure that all our patients will be able to receive timely and adequate care. How will MOH monitor the situation to ensure GPs are well equipped to deal with increasing workload, as well as will there be a support channel for both the patients as well as the GP to share feedback? This is not to encourage patients to complain, but for MOH to seek meaningful feedback and to provide necessary support if the clinics are facing difficulty in coping. The last thing we want is for the national care standards to drop and patients be left in the lurch. Will MOH now requires GP that's enrolled under this scheme to operate a certain numbers of hours on specific days or specific times of the day? There are clinics who open only half a day on certain days of the week. Many do not operate on weekend and public holidays. What will happen to patients who require medical care when their GP clinic is closed? What is the contingency plan if GPs will be away for extended period of time, be it professional or for their personal reason? Are enrolled clinics required to have more than one GP, or would they have to hire a standby to inform MOH if they'll be away? Will there be a backup, which means that a first-line GP, a second-line GP clinic that is being arranged, which instead of appointing one, you have to appoint two, which means that one standby. To get a clearer picture on GP's interest on the one residence, one doctor scheme, we need more statistics. Currently, how many GPs are practicing on a part-time basis? These GPs may not be able to accept major cases or cases requiring commitment for long-term follow-up. How many GPs are participating in the primary care network? What percentage of the GP nationwide does this constitute to? So in conclusion, Madam Speaker, good health is our personal capital asset. Responsibilities for health should be a collaborative effort among individuals and the societies that we live in. We all have to look after our health. At the same time, many may not be well-versed in healthcare matters and would greatly benefit from a healthcare profession by their side to walk them through this healthcare journey. We cannot put this plan into execution without the strong support from our GP. During the pandemic, widespread burnout causes an exodus of healthcare staff around the world. Singapore experienced our highest turnover rate of healthcare workers over the past 2 years, and yet even before that, the healthcare workers have voiced their discontentment with long, inflexible working hours, the abuse, the disrespect they face from patients. The pandemic has pushed this stress faced by healthcare workers to the breaking point. As we recover, we must ensure that Singapore continue to be safe, conducive, and an inviting place for all our healthcare workers, including our GP. With that, Madam Speaker, I support the White Paper.